me.
Okay, welcome everyone. I am Allison Hancock, the Executive Director of Breast Friends, and we are so happy that you joined us this afternoon for this presentation. We have Parisa with Natera, and also Stephanie, who is going to be the presenter. And Stephanie is a nurse practitioner at Beacon Clinic, that's in Idaho. And she received both her Bachelor of Science in Nursing and her Master of Science in Nursing as a family nurse practitioner from Washington State University. She is also certified by the American Academy of Nurse Practitioners. Stephanie is an incredible practitioner with a passion for oncology care, and she has 24 years of nursing experience, with 20 of those years being in oncology. She has over 10 years of experience as an oncology nurse practitioner and has worked in many aspects of cancer care, including medical oncology, surgical oncology, and radiation oncology. Her special interests include education and symptom management. So we are so happy and thrilled to learn more about Signatera and ctDNA testing. And I will have Stephanie take it from here.
Okay, thank you very much. I just want to make sure that you can see my screen that I'm sharing. Make sure that I've gotten that all taken care of.
Yes, looks great.
Okay. So thank you very much for the introduction. So I have been working in oncology for 24 years and been through multiple new treatment revolutions and options, and there's not many things that have sparked my interest and made me as excited as the Signatera has. We use it in our practice in all solid tumors, and I'm excited to talk to you guys about how we can use it in breast cancer. So Signatera is a test that's used to evaluate for molecular residual disease in patients of all solid tumors, but has been approved by Medicare in breast cancer patients stage 2B and higher in all subtypes. Before it was only being used in triple negative breast cancer, but is now in all subtypes. And it can help us evaluate patients' response to treatment or early detection of recurrence in the surveillance setting. So this is actually just talking a little bit about the Signatera, or the actual Natera company. So Natera as a company has been around for more than 10 years. They have more than 5 million tests performed. They have 3 different divisions, but we'll be specifically talking in the oncology division about Signatera. Broken down in their oncology division, they do have a whole exome sequencing test panel that I'm sure your physicians have heard you or have talked to you about, next generation sequencing, to see about targeted therapies or molecular changes in your specific cancer that we may be able to target. They also have Empower, which is a hereditary cancer test that can be used. But we'll specifically be talking about Signatera, which is the molecular residual disease assessment tool, and how we can use it. This slide just talks to us a little bit about the process and how they're able to isolate your circulating tumor DNA from your tumor. So what happens is they send your specific pathology slides, either from biopsy or from surgery, to Signatera. What they do is they sequence out your normal germline mutation. So every normal mutation that you have in your body, they pull out, and they just specifically look at the mutations in your cancer. They search for the top 16 clonal mutations in your specific cancer, and then use that as a guide to search for disease recurrence in your blood. So this is very specific to each individual person because they're using your circulating tumor. So this is just looking at why we should use circulating tumor DNA to assess for molecular residual disease. And circulating tumor DNA is small pieces of DNA that are produced by cancerous cells or tumors. And as those cells get broken down or die, they release these cells into your bloodstream. And ctDNA is used to evaluate that disease or those DNA pieces that were broken off from your tumor in your blood, in your circulating blood. The impressive thing about this is it's a real-time marker, and normal half-life is less than an hour. So this right here is, I just threw this in here just as a explaining how easy it is, or showing how easy it is to see the results of this. Up on the top, on the left-hand side, it tells you whether it's a negative or positive. In the middle, it shows a trend over time of your results. And then on the bottom, you can see a timeline of your results. You can see that this person had positive circulating tumor DNA in January of 2021. And then throughout their treatment, they had become negative and then continued to be negative. So we all know that there are multiple different treatment modalities for breast cancer patients, and there are a lot of tools that we have to help decide, should you have adjuvant therapy, should you have extended adjuvant therapy, who's high risk versus low risk. But none of those tools are, nothing that we have is 100%. And having one more tool in our belt to actually help people make an informed treatment decision is important. So this slide actually is a little bit scary to know that up to 30% of women with no evidence of disease after curative intent therapy will actually relapse. And so having something that can identify an early relapse before patients are symptomatic is quite important. And we know that on the stuff that we have right now, as in tumor markers like a CA2729, those are not very accurate. They can be affected by inflammation in your body. And also, in order to find something on imaging, you have to have thousands of cells together in order to be able to see that, or millions of cells, actually. So if we can find something that can look for minuscule circulating tumor DNA cells, that would be very beneficial to both patients and their providers. This slide just tells us the variable different areas in your treatment that you can use circulating tumor DNA. We use it a lot for neoadjuvant response monitoring. When we have patients on treatment before surgery, trying to evaluate whether that treatment is working or not. And then post-surgical, looking to help identify patients that have evidence of circulating tumor DNA post-surgery, who are in that high-risk population and might benefit from more adjuvant treatment. And then in the recurrence monitoring, watching those patients over time to see, are they having an early recurrence? Is their therapy working? Do they need to be on therapy? And then once patients are back on therapy or happen to be metastatic, watching to see if treatment's working or not. And that helps us determine whether we need to change therapy. So I did just put a couple examples of how we have used Signatera in our practice. And we use it, like I said, in multiple solid tumors, but I just gave us a couple breast examples here. So MO is a 56-year-old woman diagnosed with triple negative breast cancer, so estrogen, progesterone receptor negative, and HER2 negative cancer. She was diagnosed in December of 2023. She had high-grade tumor, which was grade 3, which a lot of triple negative tumors we see are grade 3. We did Signatera on her initial treatment day when we were starting chemotherapy prior to surgery. And she was starting on chemotherapy and immunotherapy prior to surgery. She showed positive at 6.81. She continued her neoadjuvant treatment and was shown to have Signatera response. When she had surgery in July of 24, her Signatera was negative right prior to surgery. And then her surgery confirmed she had complete pathologic response, which was great. So at this point, she continues on her immunotherapy for a planned year, but did not need any additional oral chemotherapy. And then we will continue to monitor her Signatera, and so far she has remained negative. This next patient is a little bit more complicated, and it shows how we can use it in patients who are struggling through therapy or having a more difficult time and helping us decide what treatment to use. So LS is a 66-year-old woman diagnosed in November 22 with actually triple positive disease, estrogen, progesterone receptor positive, and HER2 positive disease. She again was also a grade 3. She started neoadjuvant chemotherapy and HER2 directed therapy in December of 22. She had significant issues with chemotherapy, including severe anemia. She actually was anemic before she even started treatment, with unknown reason for it. All of her anemia workup was within normal range, but she had significant anemia. She finally did complete 6 cycles of treatment with some adjustments. And then her surgery in December of 23 demonstrated residual disease. So we had wanted to put her on more aggressive HER2 directed therapy in the adjuvant setting because she had evidence of residual disease, but her anemia was extremely limiting. She was actually requiring blood transfusions every other week. So treatment at that time had to be put on hold. Crazy enough, she ended up with a splenectomy due to anemia. It was a spleen issue, and her anemia resolved post splenectomy, but her treatment had been on hold for several months. Since her treatment had been on hold for several months, we considered holding further IV therapy because she had been so toxic, and just continuing her on aromatase inhibitors. However, her Signatera became positive in July of 2024, and it came back low positive at 0.73. So we repeated that 6 weeks later, and her Signatera, as you can see, has gone now up to 3.29. So at that point, it's telling us that the aromatase inhibitor that she's currently on is really not doing enough. And it tells us that we need to now go back to more aggressive therapy. Having a Signatera positive at 3.29, we don't see anything on her imaging. So it's something that we use to have a good conversation with this patient, just saying, at this point, we don't see anything on your imaging. However, the circulating tumor DNA that we see has significantly gone up 0.73 to 3.2 in just 6 weeks. That's telling us that something is going on there. And we use that to have an informed decision conversation with the patient to decide, do we want to wait a little bit longer to see if you have evidence of disease on imaging, or do we want to move to something more aggressive at this time? And it's a tool that we use in our practice to help patients have more informed decisions so that we can have that all together. We're not driving it. I don't have any evidence that she has disease on imaging, but this is very impressive that it's gone up this much. I do have patients in other disease processes. This lady, I can't tell you at this point right now, but I do have other patients in disease processes that we have found positive Signatera 12 months prior to being able to see it on imaging. And studies have shown us that Signatera can show positive up to 12 months earlier than imaging. So the third case that I have here is another woman with triple negative breast cancer diagnosed in June of 23. Her initial Signatera was low-level positive. She didn't have a large amount of disease, but she was triple negative. So we did go forward with neoadjuvant chemo and immunotherapy. At the time of her surgery, she had complete pathologic response and negative Signatera. She has continued on her adjuvant immunotherapy with Keytruda and actually has her last dose in the next couple of weeks. And Signatera has continued to be negative for the 6 months post her surgery. Our plan is to continue in the adjuvant setting. This woman will finish her adjuvant Keytruda, and we will continue to watch her Signatera every 3 months for the first 2 years, and then stretch it a little bit further. This slide is just a summary of kind of everything that we've talked about for the last 20 minutes or so, showing that Signatera is now Medicare covered for stage 2B and higher breast cancer for all subtypes. And Parisa will talk a little bit more about the financial aspects of it. And then just looking, this is just also showing where we can use it. Prior to surgery, monitoring neoadjuvant response to therapy. After surgery, telling us those patients that are high risk who have positive residual disease or positive ctDNA post-surgery, showing us that they actually have molecular residual disease. And we know that those patients who have evidence of positive molecular residual disease post-surgery are in that higher risk population and do have poorer prognosis. And then in that surveillance setting, we use this a lot to just monitor patients for early response, because we do know that this can show positive, like I said before, up to 12 months before standard imaging. And then the important thing here is that Signatera detected relapse with 88% sensitivity in ctDNA positive patients. So we know it has good sensitivity, good specificity, and is just one more tool that we have in our tool belt to help women make more informed decisions on their care. Any questions?
If you have any questions, you can either unmute and ask, or you could put your questions in the chat.
I have a question. Hi, can you hear me?
Yes.
Yeah. Okay. So when I have brought up the use of this test to my doctor, she has come back with, well, I don't really want to order the test because if it's positive, we don't have a then what, like what to do. So are you able to speak to that at all? Like, is it, in that case, is it just kind of like for knowledge? Because it seems to me, you know, of course I would like to know if my tumor is coming back, but then it's also scary if there's nothing that can be done. So is it better to be in the dark, or, you know, are you able to speak to that at all?
Yeah, I could, sorry.
Oh, go ahead.
I can tell you that we have this discussion a lot, and the way that we utilize it in our practice is, like I said, to just help make more informed decisions. Because I do have a lot of physicians who say, well, what am I going to do when it's positive and I don't see anything on imaging? Do I really change this person's treatment, or do I hold and watch and wait? It's in our practice, I can't tell you that we definitely push someone to start treatment when we see the change, but we do have a discussion with the patient and say, okay, this is showing us that significant changes. And we don't go on just one positive. we repeat at 4 to 6 weeks. And if we see 2 subsequent rises, that's when we have the discussion with the patient that, hey, this is here, this is what it's showing us. We can continue to monitor, or we can change your therapy at this time. So I think it's just a great tool in order to help people make more informed decisions on their care.
Yeah, and I would definitely second that. I think the most important thing that providers need to know about Signatera is this test is really meant to be used longitudinally. There are a number of tests out there where it's kind of a one and done, and that is not the case with Signatera. So yeah, seeing those trends in the ctDNA, whether it's rising or falling, that should be giving an indication to the provider on how treatment is going for that patient. So yes, we always say to repeat testing if it turns positive. We even have a letter for PET and MRI scans that we can provide to providers based on a positive Signatera result. They can then use that letter to submit to insurance to ensure that those PET or MRI scans can get approved, because sometimes it'll show up there before it shows up on, a CT scan. So we really say, as Stephanie said, this is just an additional tool, and there's ways to monitor you, a little more closely if and when it does pop positive. Does that help answer your question?
Yes, thank you.
I have a quick question. So can this be done through just a blood test? Because it's been 3 years since I had my surgery, and I don't know how long they even keep the biopsy tissues. I have no idea.
Yeah, so right now we still do need the tissue, but typically path labs hold on to that for multiple years. We've had tissue as far back as 10 years before that we've tested for Signatera. So we can always check with the path lab. 3 years, they should definitely still have it stored somewhere. But right now we do need it because that tissue is what we're using to create the personalized assay for you. We are working on a, tissue naive test, AKA blood only, but that is not yet available.
Okay, thank you.
Yeah.
And I think actually pathology labs are required to hold tissue for 10 years.
I think we got some in the chat. It looks like we have one that said, I had stage 1 ER/PR positive. My naturopath wants to order it for me, but my oncologist isn't on board for the same reason as current speakers suggesting they wouldn't know what to do with the information. Does something like do you know what Prenuvo? I'm not familiar with that. I'm sorry. Scan would show.
I'm not 100% positive. I think that's more of a like thermal scan. Is that and I don't a thermal scan I don't believe would show as early as the circulating tumor DNA test.
Is there a reason the naturopath can't still order it? Is it just because we do have a number of naturopaths ordering this for that exact reason in this area. If they have an oncologist that's just really adamant about not doing it for whatever reason, we do have naturopaths that will order. I also, any of you can always feel free. I can put my email in the chat as well. Feel free to email me if you have an oncologist that won't order and you want to maybe go to another oncologist. I can let you know the oncologists in the area that are ordering within your insurance network, if that helps at all as well.
And she replied back and said it's a full body MRI. So just as we had said before, the Signatera has been shown to show positive results in up to a year earlier than standard imaging, whether that be CT, PET, MRI.
So there are a number of, I just popped my email in there as well for you guys. There's a number of clinics ordering the Portland area. I think it would be better to know, maybe based on like if you have Providence Insurance or OHSU or something, I could probably narrow down that list because in all honesty, most of the clinics in the area are ordering. It's just a matter of which providers within the clinic. So if there's a specific insurance or a specific group that you want to work with, please just feel free to email me. I'm happy to give you a list of the breast providers that are ordering.
I also think it's going to start to be ordered more frequently now that it is for all subtypes, and there was actually information presented at ASCO that shows benefit. It's actually listed in the National Comprehensive Cancer Network guidelines in multiple solid tumor types. So it's something that is probably going to increase in popularity over the next year. It's just some physicians who have been practicing for a while are unsure of the results in the data.
Yes, and we are working with to get into NCCN guidelines, which is, the guidelines that oncologists typically follow for treatment and, drug options and all of that stuff. So we are working to get into guidelines. It just takes a really long time to get there. So in the interim, providers should still be, trying to order this for patients if they can. And then I can also speak to billing really fast. Perfect timing on that question. So as Stephanie mentioned, we are covered by Medicare stage 2B and higher. So it's also in any stage now. So neoadjuvant, adjuvant, surveillance, it doesn't matter. For Medicare, we have coverage. If you have a private insurance, what's happening at the moment, and we don't know when this will change, but it's been like this since I've been here for the last almost 5 years. We will bill private insurance, Blue Cross, Blue Shield, Cigna. If they decide to deny testing, we won't balance bill the patient. So if they say we're not paying for this, there will be a $0 out of pocket for the patient at this time. We are working to get in network with a lot of these insurance companies. The only time a patient would owe money at this point is if it is covered. So if we do have a local payer that's like, yes, we're going to cover, you would just owe your copay and or deductible, same as with an office visit. It kind of works the same way. And that's the only time, but those are very, very rare. Majority of the time, patients currently have $0 out of pocket. I don't know if you want to take that question, Stephanie, the one from Monica. Are you able to see it? Do you want me to read it?
No, I just had to unmute myself. Sorry.
Oh, okay.
So, I think this is a good question. Why isn't it used after surgery prior to chemo and radiation? And if it's negative, wouldn't that be a good argument for not proceeding with chemo and maybe radiation too? So I do know some physicians that use it in this realm. And because it's not standard of care yet, it's not something that people will rely on 100%. At least nobody that I know at this point will rely on 100% to tell somebody in a high risk situation to avoid chemotherapy. I know it's used in combination with Oncotype DX, which will look at your recurrence risk score to help try to decide whether you should have chemotherapy or not. And still in the guidelines, if you have node positive disease, the recommendation is for radiation. I can't tell you how much that will change the more data that we get, but it's not standard of care yet. Something to have a good question with your oncologist about.
There's a question about the billing code. We have a CPT code that we use, but like I said, most private insurances aren't covering it anyway, so I'm not sure that code would matter at this time. Kendra, please let me know if there was a more specific reason for that question. There's the question of, does this test just monitor for the exact type of cancer that I had? For instance, triple positive, but I know breast cancer can come back and just be hormone positive or triple negative. So I mean, and you can speak to this too, Stephanie, as well, but Signatera is just, it is personalized to your tumor, but kind of how we talked about at the beginning. So we look for mutations in that tumor that stay with it throughout its life cycle, right? So even if it turns metastatic or changes in any way, those mutations that we find will be anywhere in your body with that tumor, if that makes sense. I don't know if you want to elaborate a little bit more, Stephanie, on that question.
So this, because it's using your tumor's DNA, it's only going to detect that specific tumor coming back. So say you were diagnosed with a triple positive breast cancer, it's not going to detect a lung cancer or a pancreatic cancer or something developing. It's going to detect your breast cancer.
Yeah. False positive rate. It's a great question. So kind of how, like I mentioned before, so how Signatera works is the longer this test is used, right? Since it's supposed to be used over time, the stronger that result is, right? So if you were to get Signatera and you remained negative for, let's say, 2 years, there is 97% chance that cancer is not coming back, right? So it's never going to be 100%. There's still a 3% chance that this isn't accurate, right? But 97% chance that if you stay negative, the likelihood of recurrence is extremely low. So that's why we say it's so important that this test is used over time, because if you just use it at one time point, it's still a strong biomarker, but that one time point is just that moment in time. As we said before, the half-life of ctDNA is less than an hour. So this is truly just this moment in time. This is where you stand. And the longer that test stays negative, the stronger that result becomes. Let me know if that makes sense. As far as how long do we recommend? A lot of time we leave that up to the provider. 2 years is a great, point for a lot of doctors. A lot of them will use it for about 2 years, especially if a patient stays negative, they will use it about that long. But we do really leave that up to the doctor to typically decide. Do you want to Stephanie, talk about the question that is how this test helps with patients who are metastatic?
Yeah, so this test helps with patients who are metastatic because it's helping us decide whether your disease is responding to treatment or not. So if you have a positive Signatera, say you start your treatment for metastatic breast cancer and your Signatera is positive at 100, and then 6 weeks, 8 weeks into treatment, your Signatera has come down to 65, just throwing numbers out there, that tells us that this treatment is working. If that Signatera has gone up to 120, 130, then it's telling us maybe this treatment is not working. Now, we would, in our practice, and I'm not sure how your physicians would do, but we would test that again very like in 4 weeks after that, just to make sure that we were getting another positive, and that it was actually going up, and then would change treatment sooner rather than later, rather than waiting a full 3 to 6 months on treatment to see if that was going to change. And have actually found it in multiple tumors to be much more sensitive than, say, the tumor markers that some people's physicians rely on. I hope that answered your question.
We have a question of how many years after disease do you recommend testing? Get nervous that it will return if you're off hormone blockers. So honestly, and this is why we wanted to do this with you guys, was I really want to be putting it into your hands and letting you guys have the power of, if that's what makes you feel comfortable 5 years out, you're like, I still would like to, just have that reassurance of having a test that, if it comes back negative, things are still good. I say to advocate to get this test for as long as you feel comfortable getting it. I know there might be some providers that give pushback on that, but again, let me know if you want any recommendations for providers that I know have used it, long periods of time. And yeah, I definitely recommend using it to have that peace of mind. I know I would. So
We
sorry.
we have actually decided in our practice with the physician I work with that as long as a woman is on AI therapy, we will continue to monitor it. So, initially once every 3 months for the first 1 to 2 years, and then every 6 months. And then when they're on their annual follow-up, we just still check it once a year. So that's just the way that we have decided to monitor these patients.
I think that might have just answered the next question. Yeah, so typically every 3 months within the first 2 years, and then every 6 months after that is our recommendation. But again, it can be up to the provider as well. Someone's asking if this test is similar to Foundation One. So I don't know if you remember at the beginning, Stephanie had showed that slide that kind of talked about, we have Signatera, then we have Altera, and then we have our hereditary cancer test Empower. So the Foundation One test is actually what our Altera test is. So that's the same test. So that's a comprehensive genomic profiling panel. They're typically comprised of, over 400 genes. And really what that kind of test looks for is what sort of targeted therapy might work for you. So it's looking for driver mutations that can then be paired with a drug choice or clinical trial option. Signatera is completely different in that it's a molecular residual disease. So that's really just looking at likelihood of recurrence and response to treatment. So they are slightly different tests. But the nice thing we like to do for a lot of clinics is you can get the same test that you would with Foundation with us, but you can do Signatera and Altera together with the same tissue, same blood sample. So it's actually a lot easier. It helps streamline some of that testing. I think I might have skipped a question up here. Let me go back and look. Are there any trials that we can currently participate in? That is a great question. I don't know that we ourselves have any. I know that like if you were to do our Altera testing, and let's say you came back with a positive mutation through our Altera test, it would tell you what current active clinical trials there are available in relation to those mutations. So that is something that I know that test can provide information on. Are there any other questions?
I did see one question up here about what clinics was toward the top. What clinics are doing this test?
Yeah, and I'd mentioned almost all in this area. So really it would be based on like if you want to go to a Providence or you want to go to OHCU or you want to go to Compass Oncology. If I know a specific clinic or a specific area in Portland, I'm happy to give you a list of breast providers there that do it. And so please email me, psaki@natera.com. I'm happy to help.
And is Kaiser, do you work with Kaiser as well?
So so we are not in network with Kaiser. So what will happen right now is the same as with private insurance. We're going to bill them and they're probably going to deny it. And then the patient just won't have an out of pocket at this time. We'll let you guys know if and when that does change though. Let's see. Why does my oncologist want to wait for a couple of years? What will happen during this time apart from increased comfort on their level? Great question. Yeah. I think a lot of the anxiety that, I always get oncologists that say, this is just going to cause anxiety for my patient. And I truly believe it's kind of the opposite, right? I think it really is going to help the patient feel better to know, have more information. And Stephanie, correct me if I'm wrong, but to have more information rather than less. I think a lot of the, you know, feeling uncomfortable is really them being scared about getting that positive result. I haven't heard of a doctor wanting to say they want to wait for a couple of years. Stephanie, have you heard anybody say that? And what are your thoughts on that?
I haven't heard physicians say they want to wait a couple of years, but I have had multiple physicians who feel like a positive result will cause more anxiety in their patients. And in that realm of you can't see anything on imaging, but it's positive, what do we do? And I have this conversation with physicians or providers a lot. In our practice, it has actually decreased patient anxiety because it's one extra thing. If it's negative, that's amazing. You have no evidence of molecular residual disease, but I feel like patients these days are so much more in tune with their treatment and have a lot more research, are very data driven. And so having that, even if a positive pops, it's more information for the patient, and it actually helps us have much better conversations. So the providers who tell me they're nervous that their patients are going to have more anxiety, that's really not what we've seen in our practice. And we use it in our practice, like I said, throughout all solid tumor types and anybody who's on immunotherapy. So we use it quite often. I've had multiple positives. I've had patients who just completed their adjuvant chemotherapy, and a month later, theirs pops positive. A month later, it's doubled. So having those conversations with patients and deciding at what point to put them back on treatment, but it helps the patient because we're having a discussion together as to what's their comfort level. Are you comfortable waiting longer to see if something shows up or when something shows up? Or are you comfortable restarting treatment right now when we have very little evidence of metastatic disease and you're in a much better place now to start treatment than if I wait 6 months and you have liver and bone mets? Those are the type of conversations that we have. And I feel like it's actually decreased the anxiety in our patient population.
Yeah. And Allison, I see you kind of mentioned that it's more about, feeling unsupported by the oncology or their team. If you want to email me separately, I'm not sure who you're seeing. I'm happy to either try to talk with them, or because it could be, since so many providers in this area are using Signatera, there's a strong likelihood that whoever your providers are, there's someone else within their clinic that is ordering the test. So I'm more than happy to, try to speak with whoever at the clinic, or if you want any other suggestions from a clinic that I know is supportive of the test and supportive of the results, I'm happy to help that as well. Yes, Allison, I think there's going to be a recording, right, that you're going to end up sharing with everyone.
Yes, I'm going to send out a recording probably either this afternoon or in the morning. And for all the participants who participated this afternoon and those who weren't able to join us, the recording will be available. And I'll send out that link.
So there's a question of, do we have to have a tumor of 2B to request the test? No, so we can do any stage cancer technically. We were just saying that Medicare covered stage 2B and higher, but really the providers can order on any stage. Again, if it's denied, right now we're not balance billing patients.
Okay, any other questions?
I'm considering pausing treatment to try to get pregnant. Is this test used or could be used for monitoring while I'm pausing hormone suppression? Yes. Stephanie, have you used it in that way?
We have not used it in that way, but I do have a provider in the area that has used it in that way.
Yes, that is a good place to use a test just to see if you're staying negative. Anything else?
Well, I want to thank you again for coming. And I'm a 19-year breast cancer survivor, so I've seen a lot of changes that have come up. Back when I was diagnosed, they didn't even have treatment for HER2 positive. So it's come a long way, and I'm very thankful for all the research and all of these testings like this that can provide informed decisions. And so we will definitely be sharing this and really encouraging all of our medical providers and our patients to be an advocate for themselves, to take this to their providers and get that information.
There's one last question. It looks like they were just wondering how long Signatera has been around. So it's been about a little over 5 years now. I started with this group about 4.5 years ago, and I was one of the first sales reps in this area. So it hasn't been around too long, and it's definitely, as Stephanie said, growing some popularity, luckily and thankfully. So it shouldn't be too hard to get whatever providers you need to order it.
Okay, thank you again, Stephanie and Parisa, for coming and sharing your lunch with us. And again, the recording will be up, and so please share it.
All right. Thank you.
Thank you, everyone.
Bye.